Welcome to Med School Tutors 15-minute question dissection. My name is Marcel Brus-Ramer. I'm a senior instructor at Med School Tutors and director of outreach and promotion for Med School Tutors. I've been working for Med School Tutors for several years now, and today we're going to go through a USMLE style question, a USMLE Step 1 style question, and then go through the relevant review for that question. As a way of a little bit of background, I'm a graduate of Columbia University, where I did my MD and PhD, and currently I'm a resident in the Department of Radiology at UCSF in San Francisco. Okay, so let's get into our 15-minute question dissection without any further delay. So, in today's question dissection, we're going to go over the question and then look at the answer choices. And we're going to talk about some of the relevant physiology. Then we're going to move on and talk about some of the relevant biochemistry for this question. And finally, we're going to try to integrate that information so that we can come to an answer. So let's get to the question first. I'll read it and give you a chance to read it along at home. A 77-year-old Caucasian female with a 10-year history of atrial fibrillation and hypertension has been mistakenly taking twice the normal dose of Warfarin for the past 2 weeks. Her INR is 8. On physical exam, she shows no signs of bleeding. Her hemoglobin is 11.9 and platelet count is 220,000. You decide to treat her orally with a specific nutrient intended to reverse the toxicity of Warfarin. Post-treatment, what is the primary mechanism by which coagulation factor activity will most likely be increased in this patient? Okay. So, we have a number of answer choices here. And we can see from and we're going to read through those answer choices next. Answer choice A, increased post-translational modification. Answer choice B, decreased cyclic AMP production. Answer choice C, activation of nuclear gene transcription. Answer choice D, opening of ligand-gated ion channels. Answer choice E, phosphorylation of dimeric cell surface receptors. Answer choice F, decreased activity of CYP450 enzyme in hepatocytes. Okay. So looking at this question and the answer choices, we can see that we have a woman here who has atrial fibrillation, has been taking a lot more warfarin than normal. So clearly she's much greater risk of bleeding than normal. Her coagulability is markedly decreased. And our answer choices, what we're seeing here, is that they're talking about cellular physiology and biochemistry processes. So this question is clearly testing us on our understanding of both atrial fibrillation and the use of warfarin, but also on the cellular physiology and biochemistry related to warfarin and probably related to its mechanism. So before we get into the actual answer choice, I think it's relevant that we talk about atrial fibrillation and why a patient would take warfarin. Also, it'd be important to understand a little bit about the basics of coagulation. So in a quick review of the physiology, let's first talk about atrial fibrillation. Well, in this diagram here, what we have is a heart, and in the heart we have some numbers sort of laying out the direction of electrical information as it's passed through the heart in normal conduction. So electrical signals in a normal heart will start up in the SA node, up in the atria, can be conducted down to the AV node that lie between the atria and the ventricles, and then from there it'll be conducted to both ventricles in a coordinated fashion so that they can contract effectively, pushing blood out to the lungs or to the systemic circulation. Now in the case of atrial fibrillation, what's going on is that the electrical signals up in the atria are disorganized and are coming from multiple different locations, not just the SA node. These signals are filtered by the AV node so that there's no ventricular fibrillation, but the effects of atrial fibrillation are pretty significant. And that's because when the atria are poorly coordinated and don't contract well, blood tends to pool. And when blood pools, it leads to the formation of clots. Those clots can be ejected from the atria into the ventricles, and then from the ventricles passed on into the systemic circulation or into the lungs. And particularly, we're worried about those clots that are sent from the left ventricle into the systemic circulation. Now, before we get into what those clots will do and what organs will be affected, we need to think briefly about why patients are on warfarin. Well, warfarin is used in order to prevent the formation of these clots. So what warfarin does is reduce the patient's coagulability. And it does that by affecting the coagulation cascade. So here we have a diagram of the coagulation cascade. And for most of you, you've probably seen this at some point in your training. Now, it's important to understand that for warfarin, particularly, its effects are going to be at factors 10, factor 7, factor 9. It can also affect factor 8, and particularly also factor 2 in its effect on factor 10. And that's warfarin's anticoagulant effects. It's blocking these procoagulant factors. But it's also important to note that warfarin can affect protein S and protein C. These are natural anticoagulants, and warfarin can actually block these before it will block the procoagulant factors, such that warfarin initially, when it's initially given to a patient, because it blocks protein C and S first, can actually be procoagulant. And this is an important side effect of warfarin, an unintended side effect that is commonly tested for the USMLE. Now, we've talked about warfarin and why we need to use it to block, why we use it to help prevent the formation of these clots, which can become emboli. But we need to think about where these emboli are going to go. Why are these emboli so bad? Well, that's because they become emboli to important organs. And the organs that are very susceptible to these thromboemboli, basically emboli from blood clots or thrombus, is because they can go to the brain, they can go to the kidneys, they can go to the spleen, they can go to the intestines, and also go to the limbs. These are classic areas where thromboemboli can go in the setting of atrial fibrillation, and that's why a patient takes warfarin. Now, one of the other things that's commonly tested about these things is what the appearance looks like, and there's a set of keywords that are used to help describe this. And here we have a axial CT, basically a cross-section through the abdomen with a CT scan, and we're at the level of the liver and of the spleen, and we can also see the stomach here in this CT. And this is a contrast-enhanced CT. What we see in this contrast-enhanced CT is that in the spleen, there's this kind of wedge-shaped defect that's low density. And what that's reflecting is that there's a wedge-shaped area of lack of blood flow due to an embolism. This is a classic appearance of a wedge-shaped infarct in the spleen. And we can see this commonly in the spleen. It can also occur in the brain, where it would be called a stroke. It could happen, of course, in the kidneys, and it could happen in the intestines. The limbs are also a lesser known, but also very common area of embolism from these thrombi. Now, we've talked about the organs that are susceptible to thromboemboli, but what about organs like the liver, pancreas, stomach, and lungs? These rarely, if ever, get wedge-shaped infarcts and are much less susceptible to thromboemboli. And that's because in the case of the liver and the lungs, they have dual blood supply. In the case of the pancreas and the stomach, there are copious anastomoses. So there's blood coming from lots of different arteries in lots of different directions. So even if one is cut off, they still receive enough blood supply to the rest of the organ. Now, discussion of the dual blood supply and of the liver and lungs is beyond the scope of today's discussion, but it's something that's important to understand when moving forward and thinking about these organs. Okay, so we've talked about some of the relevant physiology, discussing atrial fibrillation and how it forms clots, some of the basics of the coagulation cascade, and then why those emboli are so dangerous to the body. Now I want to talk a little bit about the relevant biochemistry. And what we need to do here is think about warfarin specifically. We need to think what's going on in warfarin and what is its mechanism. How does it affect coagulation? Well, warfarin's mechanism, warfarin is important in preventing the activation of vitamin K. And the site where warfarin acts is by blocking epoxide reductase. Epoxide reductase is an enzyme that will activate vitamin K so that vitamin K can function as a cofactor in the maturation of coagulation factors that we've mentioned before, such as factors 2, 7, 9, 10, and protein C and S. So warfarin's effects are on preventing vitamin K from being active. Let's talk a little bit more about vitamin K before we move on to some of the specifics of this reaction. Vitamin K, as we can see here, has a ringed structure, and what this ringed structure implies is that it's fat-soluble. Vitamin K is among a group of vitamins that are fat-soluble, and it's important to remember that A, D, E, and K are all the fat-soluble vitamins. And we'll talk about that at the end of this discussion about why that's important. But when we think about fat-soluble vitamins, we need to think about them as functioning similarly to steroids, or that is, in most cases, functioning similar to steroids, and that they're able to pass through lipid membranes. Okay. Now, when we think about vitamin K in the setting of this reaction, the maturation of coagulation factors, we need to think about what it actually does. Well, vitamin K serves as a cofactor for the carboxylation of glutamate residues. So again, the gamma glutamate residue is going to be carboxylated in the setting of vitamin K, and so that allows the maturation of these various proteins so that they can be active. This is the reaction here that we're talking about. Vitamin K is serving as a cofactor in the carboxylation, or the adding of a carboxyl group to a glutamate residue in a coagulation factor. And we can see that vitamin K is not actually being used up in this reaction, but it's just simply present in an active and then inactive form. Now, when we think about this reaction, the carboxylation of these coagulation factors, we need to think, where is it taking place within the body? And more specifically, where is it taking place within the cell? Because this is actually a commonly asked question. What we see here is a diagram of a cell with some of the various important organelles that are commonly discussed in cellular physiology and on the USMLE. What we can see is that we've placed this reaction out in the cytosol, but the implication is that this is a modification of a protein. And if we think about where proteins are created, they're created on the rough endoplasmic reticulum. Basically, RNA that's been transcribed from DNA translocates out to the rough endoplasmic reticulum, and there that RNA is translated into a protein. And once that protein is translated, at any point after it's produced, it can be modified. And so in this case, this is a post-translational modification, and it can occur anywhere from the rough endoplasmic reticulum out until it's out into the cytosol, or its packaging in the Golgi. Any of these points out here. What's important to understand is it's not happening within the nucleus. Okay. Now, we know where this reaction is taking place generally within the cell. We also need to think about where this reaction is taking place within the body. Which organ is it taking place within? And if we take a look at our picture of the human body again, we should recognize that a reaction such as this, particularly related to coagulation factors, is taking place in the liver. The liver is the major synthetic organ of the body, produces most of the proteins, and particularly produces the proteins for coagulation and anticoagulation. And this is a commonly tested concept. Where is a reaction actually taking place? Where is a protein actually being produced? In this case, it's going to be in the liver. It's also important to note that in patients who have severe liver failure, when their liver is failing, such as from alcohol or other causes, such as various drugs, that one of the signs of severe liver failure is the inability to produce sufficient coagulation factors. That includes the procoagulant and the anticoagulant factors. And just by way of discussion, it's important to think about which coagulation factors are affected first by liver failure. Okay, so we've talked about some of the relevant biochemistry, relevant physiology, and we've just talked about some of the relevant biochemistry for this question. Now let's take a little bit closer look at the question itself and some of the answer choices, and think about how we can integrate all those concepts so we can get the right answer. So the actual question component from this long vignette is the following. Post-treatment, what is the primary mechanism by which coagulation factor activity will most likely be increased in this patient? Okay. We have our answer choices here. Answer choice A, increased post-translational modification. Answer choice B, decreased cyclic AMP production. Answer choice C, activation of nuclear gene transcription. Answer choice D, opening of ligand-gated ion channels. Answer choice E, phosphorylation of dimeric cell surface receptors. Answer choice F, decreased activity of CYP450 enzymes in hepatocytes. Okay. So before we get to the answer choices, it's important we talk about one more concept related to vitamin K. In this diagram here, we have a picture of a cell, and we have a stereotypic explanation of what's going on with steroid hormones. We have our steroid hormone here. We can see the steroid hormone passes through the cell membrane, binds to a receptor, and then ends up in the nucleus. What's important to note here is that steroid hormones, or fat-soluble hormones, or fat-soluble factors, are going to pass through the cell membrane and actually can pass directly into the nucleus across the nuclear membrane. And that's because these membranes are lipid bilayers, and so fat-soluble molecules are able to pass right through. Vitamin K is going to be able to do the same thing. It does not have to interact at the cell surface, so it can pass right into the cell, can then interact with various receptors or various reactions inside the cell, and then either pass into the nucleus or stay out in the cytosol. And when we look a little bit more closely at our answer choices, we can see that we can eliminate some answer choices immediately. And those are answer choices B, which is decreased cyclic AMP production. And the reason for that is cyclic AMP is a second messenger for cell surface receptors. It's classically associated with cell surface receptors, and we understand that vitamin K is not going to bind to a cell surface receptor because it's fat soluble, so we can eliminate that. We can also eliminate answer choice D and answer choice E, and that's because both of those are dealing with cell surface receptors. An ligand-gated ion channel is a receptor, is a type of receptor on the cell surface. And phosphorylation of dimeric cell surface receptors is stating that it's part of a cell surface receptor change. And that's not the situation here. Another of the answer choices we can eliminate is decreased activity of CYP450 enzymes. CYP450 enzymes are important to know for the USMLE Step 1, Step 2, and Step 3, but they're beyond the scope of today's discussion and are not relevant to this question. CYP450 enzymes are particularly related to detoxification of things that are consumed by the body, and so that would be relevant in another setting, but in today's discussion, this is not what we're looking for. Now we're left with two answer choices, and if we stopped here, we could say to ourselves, we have pretty good odds. We have a 50-50 chance of getting the question right. And it's important to step back and think about this process of elimination. This process of elimination can allow us to improve our odds, and this is particularly relevant when we're in a stress situation. Imagine this is the last question at the end of a very long block. We haven't been performing too well. We don't have enough time to read through the question in great detail and think about all the various details we've talked about, from the physiology to the biochemistry. But we do need to improve our chances so we can guess better. This would be a good way to do that, using process elimination and getting down to 2, maybe 3 answer choices. Okay, but let's go a step further and figure out why answer choice A is the correct one and why answer choice C is not correct. If we think about this steroid diagram again, what we see in the steroid diagram is that the steroid crosses the cell membrane, interacts with a steroid-specific protein or receptor within the cytosol, and then translocates to the membrane. In the case of vitamin K, if we remember, vitamin K is not functioning within the nucleus to affect RNA or DNA activities. What it's doing is it's functioning as a cofactor to reactions taking place outside of the nucleus. And so we know that this is not, in this case, vitamin K's role is not to activate nuclear gene transcription. Rather, as was mentioned somewhat briefly during their biochemistry review, its function is to help in the modification of proteins after they've been translated. And so answer choice A is the correct answer choice here. Okay. So we've talked about a lot of different concepts related to this question. And while we've covered a lot of ground, there are additional questions that one would want to consider when thinking about this topic, particularly atrial fibrillation, vitamin K, and warfarin. Some of those questions might be the following. What is the most common cause of atrial fibrillation? Very important to know. How about the side effects of warfarin? How about the type of necrosis that occurs in the brain versus the kidney or in the spleen? That is definitely a very testable question for step 1. How about the types of people who develop vitamin K deficiency? Think about their ages. On the other hand, some of the things were beyond the scope of today's discussion but are still important to know. What about the CYP450 proteins? What are the most potent inhibitors and inducers of those proteins? How about reversing warfarin-induced coagulopathy in the acute setting and in the chronic setting? This is particularly important for USMLE Step 2 and Step 3. How about the mechanism of heparin? We didn't discuss heparin today, but heparin is definitely something that needs to be considered whenever you're thinking about warfarin. Heparin is the other major anticoagulant, and it's used typically in a more acute setting, but it's important to understand what its mechanism is. And then, what are the side effects of heparin? It's important to know the side effects of warfarin, some of which we discuss, but we also need to think about the side effects of heparin because they seem to be tested sort of along the same time in many questions. Well, I really want to thank you, everybody, today for listening to this 15-minute question section. And before we finish, I just want to give a little bit of information about med school tutors. As you may know, we're the leader of one-on-one medical tutoring and test preparation. We focus on preparation for the USMLE and COMLEX exams and other medical licensing exams. Some of the things that we offer our students who work with our instructors is that we personalize all of their study schedules and the way that they are personalize the teaching and explanation to focus on their weaknesses and help to improve their performance, whether they're looking just for a passing score or they're looking for higher levels of performance. The ways we do that through balance of review and retention, and also focused practice that's in an instructive way, so that it involves focused review, and it helps to make sure that all areas of their performance are at the highest level of the student performance. We do that by targeting particular weaknesses and have specialized ways of helping students prepare for strengthen those weaknesses. Additionally, beyond just the test, we like to help our students improve their clinical reasoning. And that's important because all of our students are eventually going to become physicians, and it's important to have that strong clinical skills. Along the way, testing skills are of course emphasized, and that goes hand in hand with the clinical reasoning, as the two things are sort of intertwined very closely. Finally, we like to help. We always work with our students to help them manage the pressure of these exams, and not just on test day. There's also a lot of pressure that's surrounding the preparation for these tests. As people have to set aside lots of time to prepare for these tests, it can create significant burdens on them. And our instructors are all skilled in their ability to work with students to deal with these kind of pressurized situations and how to work through that and maximize their performance. I want to thank you again for your attention to today's webinar. We hope to see you at future webinars. And if you want to find out more information about our services, we recommend going to our website, www.medschooltutors.com.